Good afternoon, everyone. Very happy New Year to all. Welcome back to the Department of Medicine Academics DOMAP. We are starting this year with the Department of Geriatrics. Our lectures taken today and the next one will be uploaded later in our YouTube in the Department of Medicine website. The link is given here. For today, the lecture under geriatrics will be initiated by Dr. Benny Paul Wilson. He's associate professor in the Department of Geriatrics. He's finished his MD Geriatrics and MRCP course. His area of interest are in cognitive decline in older persons, mental health in older persons, and community geriatrics. And his vision, along with others, is to have all primary healthcare physicians to be trained as geriatricians by the year 2040. So let's start off with today's topic, which will be delirium. Sir will be taking this lecture for the next 1 hour, and then if any doubts or any clarifications required, you can either ask Sir directly or can put down your doubts in the chat box, which will be answered towards the end of the session. Thanks to all, and then welcome Sir for the lecture.
Hello guys, good evening. So today's class will be on delirium in the elderly, and so the topic is delirium. Delirium is a Latin word for off the track. It means off the track. And the picture here represents a derailed train. And when there is a derailed train, we know how chaotic things are, and you need multiple level of teamwork to get things right. So here in the picture, you actually see the army, the fire force, the local people, the NGOs, all working together to get this train derail situation right on track. So this is a picture which I was an ardent fan of cricket some few years back, 10 years back to be very exact. I quit seeing cricket 10 years back thanks to IPL. And this is a picture of Jack Callis getting a bouncer from one of my favorite Indian bowlers. Can anybody guess who is this? Any guesses? Anybody? Kind of. I think we should make it interactive. Anybody? Any guesses? Okay. This is Jack Callis in Johannesburg, and the bowler was Srishant. The question is here is it delirium which he had during his lifetime? No, it's a progressive, according to me, it's a rapidly progressive dementia with BPSD, which ended in a tragic situation. So the topic is, what is delirium? So what is delirium? Delirium is a clinical syndrome, not a disease. So that means we need to make a diagnosis. What is behind the clinical syndrome? It is a medical emergency, acute decline in cognitive function that leads to a physical impairment. It is a potentially reversible and a preventable condition. Most often, it can be a presenting feature of an underlying medical or a surgical condition. So that is what we need to make a diagnosis. And also called acute confusional state, acute brain failure, organic brain syndrome. Many people use it as an interchangeable word for delirium. And I like this word called acute brain failure because I like it to associate with acute kidney injury. If you know acute kidney injury, if you treat early, you get the brain back, get the kidney back. Otherwise, you will end up having some chronic kidney disease sitting there. So it is a marker of a vulnerable brain with diminished reserve capacity. We'll keep talking about this vulnerable brain again and again, because it represents somebody goes into delirium. We know that the patient's brain is not that good. So what is the epidemiology behind it? Intensive care, about 80% of elderly will have a delirium. Medical wards, 30 to 60%. Perioperative, 15 to 50%. Our study done in CMC under Dr. Anagra Krispal found that hip surgery had hip fracture perioperative period at 20 to 30% of delirium. Emergency department 8 to 17%, and this is published in Lancet in 2013. Is it an outcome predictor? Yes, it is an outcome predictor of morbidity and mortality. So delirium in ICU, 2 to 4 times risk of death. Medical wards, 1.5 times of death. Patients presenting with in emergency department have a 70% chance of risk of death in 6 months time. Patients with post-operative delirium can persist with cognitive impairment for up to a year. And post-discharge patients have prolonged impairment of ADL just because of delirium. So this is an important diagram which was published in Lancet 2013. It shows on the left side, we can see talking about the predisposing factors or vulnerability of the brain. So it ranges from low vulnerability to high vulnerability state, and the precipitating of the insult, which can be less noxious insult or a very noxious insult. Depending on that will be our severity of delirium and the length of delirium which we have. So looking at what are the predisposing factors. So in delirium it's a model where there is an interaction between the predisposing factors and the precipitating factor on the brain, which leads to the condition. So what are the risk factors or predisposing factors? Underlying dementia for sure. Older age is very much the risk factor. Past history of traumatic brain injury or any brain injury in any form, whether it's a stroke or any post-encephalitic phenomenon, sensory impairment, whether it's visual or auditory, multiple drugs patients taking, which is called polypharmacy, comorbid conditions, you name it, whichever patient has, alcohol or benzodiazepine dependence, frailty and a malnutrition state, and definitely past history of delirium. If somebody has delirium in the past, you can be very sure with this admission patient is going to delirium, and past history of psychiatric illness. These are the risk factors. And what are the precipitating factors which we can list? That is, the most commonest is infection, pneumonias, UTI. Can viral fever cause delirium? Yes, it can cause viral fever can cause delirium in a patient with a very vulnerable brain. Somebody with a moderate to severe dementia will have we can have delirium even with the viral fever. So metabolic causes and electrolytes, hydration, hypo and hypernatremia, hypercalcemia, renal or hepatic dysfunction, hypoglycemia, acidosis, hypoxia, and hypothyroid. What we need to know is, in a patient, you can have multiple factors. You should be able to identify, don't stop with one and be happy about it and then proceed. You should be looking at each and every one and then looking at, on a daily basis, looking at identifying what are the precipitating causes today. Drugs, don't forget drugs. Drugs are one of the most important precipitating factors in delirium, and you can use in mnemonic acute changes in mental status. There are many mnemonics for drugs causing delirium, but let's look at some few anti-Parkinson's drug. Most of them can be a cause for delirium. Anticholinergics, well known. Anesthetic agents, very well known. So cardiovascular drugs, digoxin can can precipitate delirium. Urinary incontinence drugs like any anticholinergic, we end up using oxybutynin, tolterodine, whether it is a selective drug or a non-selective drug. even solifenacin, all of them can end up causing some delirium, definitely. Theophylline, yes. Motility drugs can cause. Corticosteroids, well-known. H2 blockers like pantidine, famotidine. And antimicrobials are one important category of causes of delirium. Give you an example, our carbapenems. If you list them, like the most noxious will be imipenem and ertapenem, followed by meropenem. Quinolones can cause, cephalosporins can cause, ceftazidime can cause. So any of the generation of cephalosporins are known to cause uh, uh, precipitate delirium. Narcotics, very sure. Any psychiatric drug can produce delirium. ENT drugs like antihistamines, any drug which we use for sleeping, there's benzodiazepine, NSAIDs, muscle relaxants like baclofen, and seizure drugs. All of this are known to, and then the list is not this, it's much more. So that is why we need to know each and every drug we introduce into a patient. And I keep repeating this to my postgraduates every day, that we are surgeons know the steps of cutting. Doctors know the drug, what we prescribe. If we don't know the drug, then we are not good physicians, what we are prescribing. So continuing with the precipitating causes, perioperative, classically hip fractures, any surgery can precipitate a acute a surgical condition can cause delirium. Pain, the most important precipitating cause. Stool impaction, urinary retention, even physical restraint. You keep restraining people, delirium gets worse and is not going to resolve if it's not if it's not stopped. Hospitalization in unfamiliar environment can precipitate delirium. Alcohol and benzodiazepine withdrawal. So it's good to know the full drug what the patient is taking. If somebody is on been on clonazepam, alprazolam for decades, and you suddenly stop it in an acute admission, then it's going to precipitate delirium. So it's full drug history is an essential component in terms of treating delirium. Pathophysiology is still poorly understood. Neurotransmitter implicated are decreased cholinergic, increased dopaminic reserve. Uh, if you look at infections, SIRS can cause a cascade of neuroinflammation, which will cause endothelial activation, impaired blood flow, neuronal apoptosis, microglial overactivation, and neuronal injury. But still is not a clear, defined pathophysiology. So I'm not going to details of it. But what I want to know is want you to know is make a diagnosis of delirium and how do you treat is what we'll aim at. Before we go into diagnosing, let's look at certain terms. What is arousal? Magnet of response to perceived stimuli. Cognition as a big definition. Consciousness is alertness plus awareness. Attention, which is an important thing which we'll assess in delirium, that is ability to focus and sustain focus. Awareness is self-perception or inward sensibility. Alertness is ability to respond to external stimuli. So let's look at how do you going to, what are the clinical features of, and how are you going to diagnose delirium. So delirium is an acute onset phenomenon coinciding with the occurrence of the precipitating cause. If you get that, you can actually be very sure of what you're dealing with. Usually the only symptom of an underlying condition. So to give you an example, when I was an intern back in 2003, I was in rounds with Dr. Alka Ganesh, ex-alumnus of CMC, and then she and medicine department, and she looked at one patient and said, "Benny, watch out for the blood culture." So this is a patient who didn't have fever, who didn't have anything related to having a infection in a common young adult scenario like fever, no chills and rigors, no localization symptoms. But the patient was very withdrawn and apathetic. And after 2 days, our blood culture grew E. coli. And that's when I realized that how important it is to look at a patient and say, oh, this patient is in delirium. Um, so delirium runs its course over days and weeks, sometimes up to a year. Uh, um, it's the recovery is usually on the slower side. So I usually say if somebody has been delirious for the last 3 days and he has reached the peak on the third day, it will take about 6 days or so, double the time to resolve on an average. So 40% take 2 weeks, 33% that take about a month, 25% for 3 months, sometimes goes up to a year, kind of, and can beget dementia. So what are the clinical features? Some more clinical features. So early delirium is the change in behavior is what we need to look at. Somebody becomes socially withdrawn, suddenly restless, anxious, suddenly becomes irritable, insomnia. We need to think that the patient probably has uh, delirium, which we need to diagnose. Why this delirium has occurred. So continuing with the clinical features, so altered consciousness is one main hallmark, which can range from somnolence to agitation. Attention. Attention is one important feature which we should be able to identify the patient is not attentive. In acutely not attentive, then you know you are dealing with delirium. Disorientation to time, place, and person. Memory impairment can be the perceptual disturbance, hallucination, visual hallucination. They have vivid uh, visual hallucinations, which actually create fear in them. Delusional thinking, psychomotor agitation and retardation, altered sleep-wake cycle. These are the clinical features. But how do you diagnose delirium? Diagnosis of delirium, the best way of diagnosis of delirium is a physician way. How do you diagnose a delirium? Is to take a good history from caretakers, relatives, nurses, therapists, and ask relevant questions to the patient. You should be able to make a diagnosis of delirium. And what a confusion assessment method encompasses is these. So let's look at what is confusion assessment method. It is one of the diagnostic tools which is used for diagnosis of delirium worldwide. And let's look at it. So feature one of delirium is acute onset and fluctuating course. So this can be obtained from the family members, caregivers, and nurses, saying that patient had an acute onset of altered sensorium, acute onset of behavioral change, and it has a fluctuating course. Like fluctuating course, and the patient is better in the morning, by night he is terrible. So this history can be got from whoever is taking care of the patient, including us. Next is inattention. A short conversation with the patient, we should be able to make the diagnosis of patient is having inattention or not. That is feature 2. So when you talk with the patient, is the patient easily distractible? A patient is getting off track. Those things is what we need to look at when we are interacting with the patient. Feature 3, disorganized thinking. Patient is here rambling, irrelevant, illogical flow of thought, and switching from one idea to other idea is what we need to look at as feature 3. And feature 4 is altered level of consciousness, which can be from normal to unarousable state, is what we can look at. So how do you make a diagnosis? Again, using the confusion assessment feature 1, 2, 3, and 4. Diagnosis requires feature 1 and 2 and either of 3 or 4. So that means acute onset and fluctuating course and inattention is an important, most important, it needs to be there. With disorganized thinking or altered level of consciousness, you should be able to make a diagnosis of delirium. But otherwise, clinically, we should all be able to recognize delirium in the earliest stage, because early stage of diagnosis leads to early treatment and leads to less morbidity and mortality. Okay, so what are the types based on our delirium types based on clinical features? So this is important to know, because hyperactive delirium, very obvious, patient will be kicking, swearing at you, you will remember it forever. Hyperactive delirium, but the patient may not remember it, that he has actually sworn at you or kicked you. But hyperactive delirium is an entity which we need to all recognize. Somebody who has become withdrawn, somebody has become apathetic, somebody who used to be bubbly and then become suddenly become not talking. Those are the people who we end up missing, and they are about 40% of. Sometimes we label them as depression. So that should not happen. We should be able to identify that the patient is having hyperactive delirium, and recognize and treat the underlying precipitating cause in them. So, and 25% are mixed. So what is the management of delirium? The first step is to say, is it delirium? And that we have already told you, early diagnosis is important. So what are the differentials we look possibilities? Are Lewy body dementia is an entity where you can actually have fluctuating course of cognitive decline. So you might end up saying that it is delirium there. Psychiatric illnesses, especially depression, can mimic an hyperactive delirium. Psychiatric illnesses, which are psychotic illnesses, can be hyperactive. We'll mistake it as hyperactive. Bipolar disorders, delirium tremens, and other uh, uh, things which we can which could be part of differential is complex partial seizure or non-convulsive status epilepticus, some causes of rapidly progressive dementias like autoimmune encephalitis and so. Um, so the next thing is to look at what is the cause of the delirium. So a thorough history and examination should be done. A complete review of system should be done. A full problem listing to look for risk factors and precipitating causes. Review of or interview of caretakers from multiple angles. Then only we'll know. It should be the person who's taking care. If you take a history from somebody whose son who's uh, not with the patient, you might miss out on the clinical findings. So it's important to take history from the caretaker, the primary caretaker. Uh, Drug list, bring the drug box, look at all the drugs what the patient is taking, assess for pain, background, baseline ADLs and memory status, and past cognitive status can be assessed using an IQ code, which you will learn in future geriatric classes. And what we need to do is a thorough examination, head-to-toe examination. It's sometimes very difficult to do a head-to-toe examination in somebody who is very agitated, but it's important to be patient and to examine thoroughly, especially look for soft tissue infections, look for turn the patient and see for auscultate posteriorly to see whether there is any Krebs or bronchial bressons, palpate for the bladder, which most of our physicians don't palpate the lower abdomen. We are happy with hepatosplenomegaly and then forget about the bladderomegaly. And next step is to do is a targeted laboratory investigation, and which includes a full blood count, urine analysis, electrolytes, glucose, renal parameters, LFT, ECG, chest X-ray. Sometimes MI can delirium can be a presenting feature in MI because the older people may not have pain, they may not say chest pain, they may not say breathlessness, they might only be delirious. So important look at ECG, chest X-ray, thyroid function, culture urine, culture blood and sputum in relevant condition, ammonia in relevant conditions, cortisol if needed, and an ABG if needed. What you look at it is I have not mentioned what casualty usually does. Casualty usually does in a patient with an altered sensorium, all of them have a CT brain done and imaging done, which is not which we can avoid in most of the settings. If you know if it is delirium, you are 100% sure in your heart that it is delirium. It is we can avoid making patients spend lots of money if they enter into CMC. So looking at the rest of the investigation, which are one is a lumbar puncture, only if it is clinically implicated, because you should know delirium in an older person is a precipitating factor is not in the brain. Precipitating factor, I'm talking about precipitating factor is not in the brain, but outside. Neuroimaging, until unless you are suspecting a subdural. If you are suspecting a subdural history of fall, then you have a focal neurological deficit. Non-ear examination, there's a focal neural. Please go ahead and do a delirium. Stroke can present as delirium. Thalamic infarcts, strategic thalamic infarcts are known to cause delirium-like presentation. So we should know how to pick that up also. And if you're suspecting encephalitis. EEG is only if we are suspecting if there is an ongoing seizure kind of disorder, which we talked about in the differential diagnosis. So rarely we shouldn't be doing a lumbar puncture, we shouldn't be doing a neuroimaging, we should be doing an EEG if we can get the diagnosis in the earlier stage. So EEG finding is slow wave. In slow waves is what we see classically, and usually we don't need it to diagnose. So how do you treat and prevent? The best way of treatment for delirium is diagnose the delirium, diagnose the underlying cause for the delirium, and treat the underlying precipitating cause and modify the risk factors, that is a predisposing factor, as quickly as possible where it is possible. Kind of. So supportive care for next is the supportive care for delirium, which is non-pharmacology, and rarely do we need to use the pharmacological measure. So what is this? So treating the underlying condition, I'll leave it to you. It's vast. It's a medical area. You will all know how to treat the underlying condition and diagnose underlying condition. Supportive care is reorientation strategies, which can be a preventive as well as a treatment. So preventive means I know this patient will go into delirium and I want to prevent the delirium. So it's in this condition is where I would like, if somebody who has a baseline cognitive decline, this is where I will encourage family involvement, family members to come and visit frequently, give them the clock, give them a newspaper in hand, ask them what date is it, encourage them to know what day is it, who has come and visited them, and so on and so forth. So that's reorientation strategies. Get them their glasses, get them the hearing aids so that the sensory impairment is avoided, and use non-pharmacological approaches for sleep and anxiety. So make sure their sleep wave cycle is reversed. I mean normalized. So safety is the next thing which we need to look at. Maintains safe mobility. Early mobilization is a very important thing in delirium. Avoid use of physical restraints, bed alarms, which will create unnecessary stress in them, which will cause them to worsen the delirium. Low beds so that they can, even if they fall, they'll not fracture. Ambulate them frequently. Get them out of the ward and show them daylight, and make sure they have people ready to, in case they jump out of the bed, so that they'll be safe to. And the normalization of sleep-wake cycle is an essential component. We want them to be awake in the morning and sleep in the night. So make them active in the morning and sleep in the night. Try from the first day of admission so that the duration of admission is not prolonged. Then looking at drugs, looking at the whole drugs, look at reduce or remove psychiatric drugs where indicated. Let's say, I mean, the most important thing is where indicated. Kind of, if somebody has been on benzodiazepines for a long time, I will not stop the benzodiazepine. I might try reducing a dose a little bit if the patient is very drowsy, but otherwise stopping it will worsen the whole delirium. Let's say, give an example of anti-Parkinson's drug. If patient is on only Syndopa, which let's say he's taking thrice a day or 4 times a day, I may not stop even if I know it might precipitate the delirium, but I know that he's been taking it for a long time. I may not stop it because if I reduce it, the mobility will come down, and rehab will get impaired. So it's a calculated decision on which drug to stop, which to reduce in dose, and which we should continue. Something which we know has precipitated it has to be stopped immediately. So Doses have to be adjusted based on creatinine clearance and hepatic impairment. Very essential that doses have to be. Give me a second, please. Sorry, my son came. So doses have to be adjusted. So based on um, creatinine clearance and hepatic impairment. So in order to reduce the toxicity. So how pharmacological restraint, I'll put it as pharmacological restraint, when will you, or pharmacological way of reducing agitation and aggression. When will you do it? It is reserved only for patients who have severe agitation. If our non-pharmacological measures have failed miserably, that is when you will have to use severe. That is when the patient is actually uh, uh, not cooperating for medical therapy or harming others. That is when we might end up using uh, pharmacological measures. So the whole aim is to start. So whole aim is to avoid it. But if in case we need it, a certain condition, we might have to use. Patient is very agitated, jumping out of the bed, thrashing people around. In that case, we might have to use these drugs. So always is low, start with low dose. Other thing is to predict who will go into it. So by morning you see a patient, and by afternoon you know the patient is winding up, and by night he's just going really. You're picking it up by 5 o'clock that he might go in really berserk. Then starting at the low dose can be. So it's good to know how it's going to worsen. So that comes with seeing more patients with delirium and seeing how the trajectory of the delirium is. Um, so many drugs have been tried, atypical versus typical antipsychotics. Both have been found efficacious, but the problem is the side effects is what we're looking at. Olanzapine is found to have prolonged delirium, so it's better avoided. So why not haloperidol? If you talk to a psychiatrist, they'll say haloperidol. If you talk to us, we'll always say quetiapine. The quetiapine is the drug which we usually end up using as an oral drug. So oral agents, what we'll end up using is quetiapine, starting dose of 12.5 to 25 mg. It's always good to start as a HSOD drug, OD, and then if needed can be made in BD. So it is very dynamic in the sense, first day you start something and then you say, you don't continue with it. You actually try either if you're getting control of the precipitating cause, then you know actually your delirium will improve. So you don't need to keep the patient on the drug. If you look at the quetiapine dose, is very small. The maximum dose of quetiapine is around around 600 to 800 mg. What we need is a very small dose in most of the patients. So, but some patients might require higher dose. Risperidone is the other drug which we can use, 0.25 to 0.5 mg. Olanzapine, better avoided. Aripiprazole is the other drug which can be used, 2.5 mg as a starting dose, and haloperidol starting of 0.25 mg to 0.5 is what we can give. So injectable agents. So injectable agents are reserved only, and it should be only stat doses. It cannot be regular doses, and only for patients who are really agitated, who is thrashing people around or biting people away or jumping out of the cot. And we know that he is not going to respond to our oral agent. Very aggressive, severely agitated patients is what. So haloperidol, always look for what formulation. That's a lactate formulation. Is what we need to IM or an IV. 0.5 to 1 mg is what we can give. In very severe cases, we can actually, if you look at NICE guidelines, lorazepam is preferred more than haloperidol. Diluted IV or a deep IM, 0.5 to 1 mg. What is the worry about all this antipsychotics is the QTC prolongation. The Western world is scared about the QTC prolongation, and they're worried that the patient will die because we give an antipsychotic, which a QT is prolonged and then cause a cardiac arrest. That is a big worry. And the other thing is the extrapyramidal syndrome, which is quite common with all these drugs. And the least is in the listed drug is quetiapine here. So that is why we end up with quetiapine more often rather than haloperidol. So next is the daily assessment. You need to assess to look at the trajectory of delirium. So if you have seen the patient thrice or twice, and you know you have 2 points to look at, and then the third next day you see the patient is better or worse, you will know the trajectory of. So if the trajectory is not good, you know you have not treated the precipitating causes very well. You have not got on top of what the disease is, underlying disease. So it's very important to know what is the trajectory of the delirium is. So look at it every day. Look how the patient is, and then you will know whether you're treating the patient correctly or not. And this has to be done till discharge, and some people will need post discharge also. So next, coming to the important thing of connection between delirium and dementia, we know that it's the disease of a vulnerable brain, delirium, and that suggests that there's the poor cognitive reserve in a patient, and and sometimes it might be an unmasking of an unrecognized cognitive decline. So patients come in hospital with a delirium, and then at time of discharge the patient is, or post discharge follow up, you realize that he has got a cognitive decline which was unmasked. When you actually get proper history, it might identify that has been a masked cognitive decline. Delirium itself can lead to dementias. So 2010 JAMA, this paper, actually meta-analysis showed that odds ratio 5.7 times risk of begetting dementia. Post cardiac surgery delirium has been associated with severe decline in cognition. Is a well-known studied entity that post cardiac surgery delirium can beget dementia. Alzheimer's dementia with delirium will never, usually don't come back to the 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 previous baseline. So I always tell my patients relatives that they'll come back to maybe 90% is what we will try to achieve. It might not be even 90% sometimes, depending on how severe the background Alzheimer's disease is. So let's look at this final one case study. So this is 73-year-old Mrs. Shanta presented to a clinic with 2 days history of decreased sleep, visual hallucination, fluctuating confusion, agitation, and aggression. He had she had one episode of chills and rigors yesterday. For the last 3 years, she's been noticed a progressive decline in her cognitive function, which is mainly memory predominant. So these are the following drugs she's been taking: metformin 500 mg, tabavil 25 mg, tramadol 25 mg for pain relief, telmisartan 40, ecosprin, atorvastatin, syndopa is what she's at. On examination, she was febrile, disoriented, time, place, and person, agitated, pulse rate was 110, and abdominal examination shows a palpable tender bladder. So it's good to to identify so what are the predisposing factors for delirium in this patient is. So it's good to categorize the thing into predisposing and precipitating factors. Predisposing factors: 73-year-old lady, so older age. There's some cognitive decline they have noticed, so definitely that is a predisposing factor. Then medications. Medications have lots of predisposes. Like somebody taking Avil is a predisposing factor. Somebody taking tramadol for a long time is a predisposing factor. Somebody been on maybe syndopa, yeah, maybe, yes, anything is a precipitating factor. So, so what is a predisposing factor? And the precipitating factor looks like she probably has a, maybe if we do an proper the bladder, which is bladder as a precipitating factor, and we might think there's a probably urinary tract infection which is sitting there, which is causing fever and chills and rigors, and that is a precipitating factor. So we need to treat this in an emergency fashion, because more as they progress in the delirium, we know the morbidity and mortality associated with it. So the take-home message is that in an older person, in a patient with less than 65 years of age, if somebody comes in a delirious state, we know the problem can be in the brain. In an older person, we should look for things outside the brain, is what we need to look at. So we should look at the infection, biochemical derangement. That is what we need to look at. The most important thing is early identification, treatment, and modification of risk factors and precipitating causes. if we identify it early and treat early, then we are on the right track. Non-pharmacological measures the mainstay. Avoid pharmacology as far as possible is a way out. This is a slide which busy slide showing early dementia, depression, and delirium differentiation, but you will get it anywhere in the web. Kind of. And here I end. Thank you. Any questions you can ask me. Anybody with questions?
Any questions, please put in the chat box. Sir, on behalf of Department of General Medicine, we thank you so much, sir, for that elaborative talk on delirium. And now we are open to questions. Please, if you have any questions, put in the chat box.
Sachipriya, please ask the question. So the question here is Sachipriya has asked us, what is the preferred drug if in case we know the patient is a known cardiac disease. So before we use the drug, we should always use non-pharmacological measure. That will be the first step. Always non-pharmacological. If that doesn't work, we will have to use a non-pharmacological measure. So what we are looking at is QTC prolongation. We are not looking at anything else generally. If the QTC is good, then we can safely use quetiapine. But what we need to look at is serial ECGs to look at whether we are actually causing any QTC prolongation. So QTC is the main thing which we are looking at here. And if QTC is not prolonged, we can actually safely use antipsychotics. But the main line of treatment will be is non-pharmacological. We should emphasize non-pharmacological measures in the treatment kind of thing, is rather than using a. So up to what dose is Sachipriya is asking? Generally, in an older person, let's say we are dealing with somebody with 70 to 75 or an 80-year-old, we would never, in a treatment of delirium, let's say quetiapine, let's look at quetiapine. Quetiapine, I've never gone beyond a dose of maybe 25 to 37.5 or even 50 max. We do not require that dose for treatment for agitation control in a patient with delirium. The higher the dose is for the psychiatric illnesses or the BPSDs which we see in dementias. We would not require that high dose in patient with pure delirium as a condition. This is small dose is what we usually end up getting. The trick is to treat the underlying condition. Identifying the treat and underlying condition, you will see the resolution of delirium as early as possible.
Any more questions, please put up in the chat box. If there are no more questions, we can end this session, sir. Thank you so much. And this lecture will be available in a week's time in our YouTube channel. And our next section on geriatrics will be taken by Dr. Prasad Matthews on dementia next Monday, sir. Thank you so much, sir.
Thank you all for listening.